Regarding the malignant tumors of the biliary channels, again, one is the epithelial and other entities are non-epithelial tumors. And if we talk about the epithelial tumors, adenocarcinomas are very much common, and they make up about 90% of the proportion if we talk about the biliary duct tumors and malignant tumors. In case of the malignant tumors, the most important thing we are concerned is about their resectability. And we actually divide them on the basis of their location. Earlier being discussed, the intrahepatic cholangiocarcinoma. We talk about the hilar cholangiocarcinoma, and we talk about the distal cholangiocarcinomas depending upon their location. One thing to emphasize here is these tumors are not very much common. They are rare tumors, but usually their presentation is very late, in late 60s. And because these are not very much symptomatic, they're silent tumors, and they actually come up in the diagnosis when they are already metastasized to the different areas and they're involving a widespread part. And especially the local invasion, if we talk about the intraductal invasion, and if we talk about the local advancement and periductal infiltration, the most common complication with these tumors are the involvement of the segmental vasculature of the liver, the involvement of the different ducts, and especially we are concerned about the portal vein. That's actually a criteria for unresectability, and the involvement of the portal vein, the involvement of the common hepatic artery, the involvement of the right hepatic artery, and the involvement of the intraductal part of the intraductal infiltration, you can say, and then metastasis to the different adjacent organs. These tumors are very, very lethal, and they're very aggressive. And if you are successful in diagnosing the tumor earlier, and then you plan a proper resection depending upon the stage of the tumor, the survival rate can extend up to 24 months. That is about 2 years after the surgery. But in case of the stage 4 or 5 tumors, which are usually very advanced, the mean survival time is only 5 months. So diagnosing the tumor earlier is very much important. Classification is important because you have to think about the proper resectability. There is another classification, which is bismuth classification. We'll be talking later on about that. But if we talk about the generalized classification, depending upon their location, do not forget about the intrahepatic part, which is the intrahepatic cholangiocarcinoma, then hilar, which is at the confluence of the right and the left hepatic, and then some part of the common hepatic, and then distal cholangiocarcinomas. In case of the intrahepatic cholangiocarcinomas, what is important is that you can go for local resections, and you have to sometimes the treatment options is hepatocoagulopathy or the choledocoagulopathy, and you combine it with sometimes with a partial hepatectomy when most of the segments of the liver are also involved. In case of the hilar cholangiocarcinoma, the option is Roux-en-Y choledocoagulopathy. And in case of the distal cholangiocarcinomas and most of the part of the common bile duct, you have to come up because they're extending to the head of the pancreas. Then the options would be local wide resection, and that would be the Whipple procedure, in which we are combining with a gastrojejunostomy, and we are making a pancreatic jejunostomy, and we are making choledoco, or you can say hepatic jejunostomy. So Whipple is a very extensive procedure, and we'll be talking about the Whipple as well. So far, the thing you need to know here is these malignant tumors, they behave aggressively, okay? And they come into diagnosis at a very, very late stage, like usually at 60s. And because of that, they're at that time they present to you in stage 4 and maybe stage 5, and the already tumor is already metastasized, and there is a local involvement of the common hepatic and a portal vein. So the thing which is important to know here is if the tumor has already gone up to, there is local advancement to the common hepatic, right hepatic artery, common hepatic artery, the portal vein, the tumor is already unresectable. And then you have to put your patient on a palliative treatment. Let's have a look on the bismuth choletic classification. There are actually 5 different types, and type 1 is actually, you can see, let me just redefine the anatomy here. This is the right hepatic duct, this is the left hepatic duct, this is the confluence, okay, and this is actually the common hepatic. And this is the cystic. The common hepatic combining with the cystic, making the common bile duct here. So the type 1 is in case of the bismuth choletic classification, is the one in which the tumor is actually below the confluence. You can see this is the confluence of the right hepatic and the left hepatic. So the tumor is below the confluence. That means it's involving the common hepatic, but it's just below the confluence. So the part of the liver is actually spared in this tumor. And in case of the type 2, it's more proximal. It's more proximal, okay? And you can see here that it's extending up to the confluence. So type 1 is actually below the confluence, and type 2 is involving the common hepatic duct, and there is involvement of the little bit of the confluence. Then there's a type 3A in which the right hepatic along with the common hepatic is involved. Then there is type 3B in which the left hepatic along with the common hepatic is involved. Then you have the type 4 in which the common hepatic and the right and the left hepatic ducts, they are involved. And then we have a type 5 in which there are multiple discrete segmental involvements. Like you can say some part of the common hepatic, you can see some part of the common bile duct, and you can also see the intrahepatic infiltration here. So the right hepatic and the left hepatic ducts, they're also involved. And this kind of a tumor would be, because large area is involved, the distal part involved, the hilar part is involved, the intraductal part is involved. So type 5 is more advanced, and you end up with a Whipple's procedure. Just glancing back to the classification, bismuth choletic classification is very much important to know, because it's going to tell you about the division, the location, and then you can plan your surgical options accordingly. And the prognosis obviously will be depending upon this. So type 1 is the part in which the tumor is below the confluence of the right and the left hepatic duct. The type 2 is which is involving the part of the common hepatic and the confluence of the right and just reaching. It's not actually involving the confluence, but partially reaching to the confluence. Type 3A is in which the right hepatic and the common hepatic is involved. Type 3B in which the left hepatic and the common hepatic is involved. Type 4 in which right hepatic, left hepatic, common hepatic is involved. It's like hilar and intraductal. And then type 5 is which is actually there are skip lesions there.